So, good morning. Today's topic is carcinoma of ovary. So, among all cancers, ovarian cancer is treatment is the most challenging because patients normally present at advanced stage when the patient is coming and when the patient is coming and we are diagnosed with the ovarian carcinoma that must be in the advanced stage of carcinoma ovary. So the ovarian cancer treatment is the most challenging, and also it has a high fatality ratio, and also it requires extensive surgery and intensive chemotherapy. So patients should be taught about the early signs and symptoms, and mostly it is sporadic in occurrence. So because why it is not recognized at earlier stages, because usually it develops after menopause when ovaries are inactive state. And also since the ovaries are located deep inside the pelvis, it is inaccessible to the examination. So we cannot diagnose the findings. And also symptoms are even non-specific to the ovarian cancer because patient normally present with bloating sensation and abdominal distension, discomfort, nausea, vomiting. So these are not the symptoms related to ovarian carcinoma. So patients always present at the medicine OPD or surgical OPD. And patients usually do not present at the gynec OPD. So normally the origin of ovarian carcinoma is three. That is epithelial cell layer and germ cell tumor and stromal cell. Cell tumor accounts for the 90% of the malignant ovarian tumors. So in this it is classified into serous, mucinous, endometrioid, clear cell tumor. And germ cell tumors usually affect the engaged people. If engaged, they are the groups. And the examples include Wisdominomas, Yolk-sac tumors, choriocarcinoma, and immature teratoma. Stromal cell tumors types of granulosa cell tumors and sertoli cell tumors. So epithelial cell tumors are the most common epithelial tumor occurring in the older age group. So these are the carcinoma which is diagnosed at the later stage. So the clinical variants of the epithelial carcinoma, ovarian carcinoma, or epithelial ovarian carcinoma, which constitutes about 70% of the ovarian carcinoma, and sex cord cells tumor, and germ cell tumors, which occurs in the younger age group, and metastatic tumors like Winkenberg's tumor. Rarer tumors like lipoid tumors and ovarian sarcomas are also present. So epithelial carcinoma, the types of the carcinoma are invasive and borderline. So invasive, in invasive only, there is serous, mucinous, endometrioid, clear cell, Brenner, and differential. Borderline tumor normally affects the 40 to 45 years of age. So it is very good prognosis. Patient will be cured with surgical staging itself, and there is no chances of metastasis. So since the epithelial ovarian carcinoma, fallopian tube carcinoma, and peritoneal carcinoma are grouped under the same classification, so they are always indistinguishable from high grade, and also it's the clinical behavior is just like ovarian carcinomas. So they are all grouped under one classification. So the pathogenesis, the epithelial ovarian carcinoma is divided into type 1 and type 2. Type 1 normally affects the young people. Type 2 is mostly affecting the older age people. So type 1 is due to the incorporation of Mullerian epithelial cells, which is due to the repeated ovulation which causes the Mullerian inclusions under the ovarian surface, which later forms as stadenomas. But type 2 is due to stick theory. What is stick theory? This serous tubular intraepithelial cells of the fimbrial end of the fallopian tube. Normally, after the ovulation, the fimbrial end of the fallopian tube normally catches the ovum from the ovary. So what happens is, in that time, the inflammatory cytokines and also the reactive oxygen species all affects the ovarian surface epithelium. So the DNA repair of the ovarian surface epithelium, if it is damaged, so it causes the um, type 2 serous ovarian carcinoma. So this is due to the exfoliation of the cells from the tube onto the surface of the ovary or peritoneum or both. It harbors the P53 mutation. So normally the fimbral end of the fallopian tube is causation for the serous carcinoma type 2. So and also type 1 is slow growing and type 2 is rapidly growing. I told because when we are diagnosing the ovarian carcinoma, that must be in the advanced stage carcinoma. And type 1 is we can easily diagnose early stage of diagnosis. And it arises from Mullerian epithelium, Mullerian inclusion, and endometrial cells. It includes all the low-grade tumors. So low-grade serous carcinomas, endometrioid tumors, and clear cell tumors, and mucinous tumors. So type 2 is rapidly growing and it is late stage at diagnosis and poor prognosis. It's more common than type 1. And as I told before, it arises from the fimbral end of the fallopian tube. It includes the high-grade tumors and transitional cell tumors and the undifferentiated tumors. So etiology, when you are going to etiology, so as I have told, the pathogenesis of the ovarian carcinoma always occurs following the ovulation. So whatever factors which prevent ovulation or the protective factors. So whichever agent is creating ovulation, that are all the risk factors. So normally what are all the risk factors are nulliparity. So because they have repeated ovulation, so they have the ovarian surface epithelium damage and also the DNA repair will affect and it causes the ovarian carcinoma. So infertility patients, because they will have the they will receive the ovulation inducing drugs, so there will be more repeated ovulations. And also early menarche and late menopause, ovulation inducing drugs, endometriosis, PID, PCOD, and also they are telling that perineal exposure to talc also is causing. So genetic factors are most important. So BRCA, BRCA1 and BRCA2 mutation and HNPCC. BRCA1, BRCA2 mutation has the 42% risk of ovarian carcinoma, but HNPCC has the 50% risk of endometrial carcinoma, but 12% risk of ovarian carcinoma is also there. So we'll see about the familial carcinoma before Chikaito. So BRCA1, BRCA2. In this, BRCA1 is more common than BRCA2. So Lynch syndrome is HNPCC. It is that there is a 12% risk of ovarian carcinoma and 50% risk of endometrial carcinoma. So in case of HNPCC, we have to do bilateral salpingo-oophorectomy, total abdominal hysterectomy plus bilateral salpingo-oophorectomy should be done in Lynch syndrome. But in case of BRCA1 mutation, we can do prophylactic salpingo-oophorectomy. Because of the risk of endometrial carcinoma and Lynch 2 syndrome, we have to do TAH also, total abdominal hysterectomy also. So what are the prevention or prophylaxis? So we told whatever causes, when we are stopping the ovulation. So these are all the protective factors. So what are the protective factors? So multiparity and breastfeeding. And if a patient is consuming 5 years of combined oral contraceptive pill, it reduces the risk by 50%. And also in case of if she is having multiparity plus 5 years use of combined oral contraceptive pill, which reduces the risk by 70%. And also prophylactic bilateral oophorectomy, if it is done at more than 35 years, which is also the protective factor. And tubal ligation, TAH with BSO, that is total abdominal hysterectomy with the bilateral salpingo-oophorectomy, HNPCC syndrome is also a protective factor. So normally with BRCA and BRCA2 mutation should undergo prophylactic surgery. As I before told, where they have to do prophylactic salpingo-oophorectomy. So if they are not willing to do, or if they have not completed the family, we can tell them to do screening strategies like CA125 marker we can do, and also pelvic examination, and also total transvaginal ultrasound we should do for the ovarian screening. And also ROCA. ROCA is serial 125 should be monitored at the regular intervals. So if it exceeds 1%, so there is risk of having ovarian cancer is low. So they have also introduced new biomarkers like leptin, osteoportin, and insulin-like growth factor. And also we should advise physical examination, that is annual pelvic examination should also be advised. And chemoprophylaxis, so as I before told, OCPs can decrease the risk by 3%. So in BRCA1, you should do bilateral salpingo-oophorectomy after the completion of family. So if it is in case of HNPCC, because of the risk of endometrial carcinoma, we should do hysterectomy with bilateral salpingo. So what are the symptoms? Because normally patient will be asymptomatic. What are the symptoms? Would be only the pressure symptoms like frequency, constipation, lower abdominal distension, pain, and also acute symptoms from rupture or torsion. Advanced stages, it is distension, bloating, constipation, nausea, and anorexia. So normally there is GOF symptom index, which is the patient will have early satiety and anorexia, and also bloating sensation, which should be present for more than 12 times in less than 1 year, which is a GOF symptom index. Patient will have abdominal distension, anorexia, and early satiety with bloating sensation. If of it all presents more than 12 times in less than 1 year. So signs or it will be solid, irregular, fixed pelvic mass. And if it is ascites and upper abdominal mass is also present, then diagnosis can vary. And normally there will be left supraclavicular lymph nodes will be enlarged, that is Virchow nodes will be enlarged, and pleural effusion will also be present. So the differential diagnosis can be benign ovarian tumors and functional ovarian cysts, PID endometriomas, non-gynecological like colon carcinoma and pelvic kidney. This is IOTA rules, benign rule, B rules and M rules, which is called B rules and M rules. So B rules normally, benignness normally occurs at the younger age and it has a slow growth. It is unilateral and it is be mobile and cystic, smooth surface. There is no ascites, there is no nodules, and uniloculated cystic, and it will have thin septations. Malignant will be present at the extremes of age and rapid growth. Bilaterality will be present, fixed and solid, irregular surface, ascites will be present. Nodules will also be felt in pouch of Douglas, multinoculated, and the septations will be larger than thick septation. And papillary projections will also be there. In color Doppler will show the neovascularization. So diagnosis, usually there is no screening method for the ovarian carcinoma. Usually the diagnosis in the early stage always requires an laparotomy. Investigation that can aid in diagnosis can be ultrasound and X-ray to look for any metastasis, pulmonary metastasis. And CT scan is done only to CT scan is only done in case of advanced cancer to find out the lymph node involved. And pap smear can be done. Endometrial biopsy can be done in patient which presents with the heavy menstrual bleeding. And tumor markers like CA125 and CEA can also be done. And ascitic fluid also can be sent for cytology. So it's before coming to conclusion of ovarian diagnosis cancer, we should exclude the colonic cancer, stomach cancer, breast cancer, and cervical cancer. So normally, pattern of spread is most common is transceromic spread, which will spread to peritoneal surface, omentum, and under surface of diaphragm. And direct extension is to the uterus, tubes, and rectosigmoid. Lymphatic, which this is the most aggressive cancer. So this will directly go into para-aortic lymph nodes. So internal iliac, external iliac, obturator, inguinal, and para-aortic nodes. Hematogenous spread will be liver, lungs, and brain. So coming to the phygostaging. So stage 1 is only one ovary. Stage 2 is both the ovaries. Stage 1, there is 1A, B, and C. So 1 is only, it is limited to ovaries. So 1A is limited to one ovary, 1B is both the ovaries, 1C, one or both the ovaries with the capsule is breached, or malignant cells will be present in the ascitic fluid. So 1C, 1 is when we are doing surgery, whereas there is a spill, surgical spill. And 1C2 is capsule breached before the surgery. And 1C3 is malignant cells present in ascitic fluid. So 1A is one ovary, 1B is both the ovaries, 1C is either one or both the ovaries with the capsule ruptured or capsule breached before the surgery, or malignant cells present in the peritoneal washings. So stage 2 is involving one or both the ovaries with the pelvic extension, that is with the fallopian tubes on the uterus. So 2A is extension to the uterus or fallopian tubes. Stage 2B can be other pelvic intraperitoneal tissues. Okay. So stage 2A is spread to the fallopian tube or uterus. Stage 2B is other pelvic structures like broad ligaments like ligaments. So stage 3 is involves one or both the ovaries with spread to the peritoneum outside the pelvis. This is stage 2 is inside the pelvis. Stage 3 is outside the pelvis and also metastasis to the retroperitoneal lymph nodes. So stage 3A is only positive peritoneal lymph nodes and all microscopic metastasis beyond the pelvis. So stage 1A1 is only positive peritoneal lymph nodes only. 1A1 is metastasis less than 10 mm, that is 1 centimeter and more than 1 centimeter in greatest dimensions. Stage 3A2 is microscopic extrapelvic involvement with or without positive retroperitoneal lymph node involvement. So stage 3B is macroscopic peritoneal metastasis up to 2 centimeters. On 3C is more than 2 centimeters, which includes the extension of the tumor to the capsule of liver and spleen, but not the parenchymal involvement. So stage 4 is distant metastasis. So stage 4A is pleural effusion. 4B is parenchymal metastasis should come under 4B. So treatment should be surgical staging and staging laparotomy and followed by optimal debulking surgery. So what are the steps of surgical staging is a patient should be prepared with pre-op investigations like CBC, blood grouping, RH typing, HIV, HbA1c should also be done, and also X-ray to rule out to exclude the metastasis, and also pap smear should be done, and endometrial biopsy if needed should be done. So if these are all okay, we should proceed with the surgical staging. So under general anesthesia, we should perform. So supraumbilical midline incision should be performed. So if there is ascites, the ascites fluid should be sent for cytology. If there is no ascitic fluid, what will you do? Normally, we'll inject the 50 ml of normal saline into the peritoneum and will aspirate and will send for cytology. So after that, we should examine the abdominal organs. So that is called stepwise exploration of the abdominal organ. That is, we should start from the cecum, that is right side. From the cecum, ascending colon and hepatic liver and transverse colon and spleen, and after descending colon and rectosigmoid. This is called the stepwise exploration of the abdominal organs. And after that, uterus and ovary should also be examined for signs of malignancy. So if there is any suspicious area in this area, we should biopsy from the suspicious areas. And also TAH, that is total abdominal hysterectomy with bilateral saphengoophorectomy should be done with infracoelicomentectomy with pelvic and paraortic node sampling or lymphadenectomy. So in advanced stages, debulking surgery should be done. So what is that? Stepwise exploration. Before that, ascitic fluid or peritoneal washing should be done. Should be sent for cytology. And after that, explorations will be systematic examination of organ and multiple biopsies. And followed by total abdominal hysterectomy with bilateral saphengoophorectomy, infracoelicomentectomy with pelvic or paraortic lymphadenectomy. So debulking. Debulking, what is the goal of debulking is the residual disease should be less than 1 centimeter. As much as possible, we should all remove all the tumors. So prognostic factors normally depends on the age of the patient and the stage of the disease, histological type, grade, and whether it is diploid or aneuploidy, and biological behavior, and volume of the residual disease after the surgery, and presence of malignant ascites, performance status of the patient, and if there is rupture of the tumor and tumor swell, and CA125 levels. These are all the prognostic factors. The risk categorization is divided into early and advanced. So early stage carcinoma is stage 1 and 2. Make it in your mind. Stage 1 and 2 is early stage, and advanced stage is always stage 3 and stage 4. So early stage itself is divided into low risk and high risk. Low risk is stage 1A, stage 1 and 2. Stage 1A and 1B. High risk is stage 1C and 2. Okay. So we'll see. So that's what we told. Low risk is stage 1A and 1B with grade 1 and grade 2. Okay. Which is non-clear cell tumors. There's no dense adhesion, which does not need any adjuvant chemotherapy to be treated. After the surgery is enough. That's all. There is no chemotherapy. In high risk carcinomas like stage 1C and stage 2 and grade 3, after surgical staging, the patient has to be treated with 3 to 6 cycles of chemotherapy. So, primary cytoreductive surgery, we have told TAH-BSO with infracolicomantectomy with lymphadenectomy, removal of as much as tumor as possible. So, what is neoadjuvant chemotherapy is, in advanced stage carcinoma, we should, because of the bulkiness of the tumor, we should reduce the bulkiness. So, before the surgery, we should give chemotherapy. After that, followed by surgery, followed by chemotherapy. This is done in advanced stage carcinoma. So, normally the indications of neoadjuvant is advanced stage carcinomas like stage 3 and stage 4. And age should be more than 70 years and weight loss should be more than 10 to 15% of their normal weight. And large bulky upper abdomen and omentum is replaced by tumor extending to the spleen. And if the tumor extends to inoperable sites like undersurface of liver, undersurface of diaphragm, we should give neoadjuvant chemotherapy, followed after which we should do surgery. Okay. So advantages, there will be subjective improvement, subsequent surgery will be easier and lesser morbidity. So lesser post-op complication and best test for chemosensitivity. So role of chemo. Only chemotherapy is needed in stage 1C and stage 2. Okay. So neoadjuvant chemotherapy will be needed in stage 1C and stage 2. Neoadjuvant chemotherapy in clinically advanced stages to achieve the chemical debulking, followed by interval cytoreductive surgery, followed by adjuvant chemotherapy. So standard chemo will be paclitaxel and carboplatin. Alternative will be cyclophosphamide and cisplatin. So what are if they are resistant? Okay. So there will be platinum sensitive and platinum resistant. Platinum sensitive will be patient will have remission. So in case of platinum resistant, patient will have the disease within the 6 weeks of the chemotherapy. So that is platinum resistance. In case of platinum resistant, we should go for second line chemotherapy agents like docetaxel, topotecan, and doxorubicin and etoposide, ifosfamide and tamoxifen. So if it is recurrence, we should do again cytoreduction surgery and followed by chemotherapy should be done. So what are the other treatment modalities is immunotherapy, hormonal therapy and gene therapy. So recent is PARP inhibitors. Olaparib has been recently used for the treatment of ovarian cancer. So follow-up should be every 3 months. So after the surgery, patient should be followed up for every 3 months for 2 years, then every 6 months for another 2 years. What you will do at the follow-up is you should do pelvic examination and also CA125 levels for monitoring of the sensitivity of the chemotherapy should be done by CA-125 levels. Okay. The survival is stage 1 will be very effective. So stage 1 will patients will survive for 80 to 90% after the treatment. Stage 2 is 60 to 70, and after the as the stage advances, the survival rate is low. So coming to germ cell tumors, as I told before, this all occurs in younger age groups. So normally, alpha-ketochlorine and HCG are the important tumor markers for germ cell tumors. Only if in case of more than 8 centimeter, which deserves the exploration. And types is most common is dysderminoma, teratoma, endodermal cavernous tumor, embryonal carcinoma, polyembryoma, choriocarcinoma. So management is normally first we have to do surgery with tumor injection and surgical staging. So because it affects the younger patient, we should do only unilateral salpingo-oophorectomy. That is when which ovary is affected, that ovary should be removed along with the fallopian tubes. The keeping the uterus and other fallopian tubes intact. After that, the chemotherapy with bleomycin, etoposide, and cisplatin. That is BEP. This is the most common chemotherapy which is used, which can be used for patients. Normally, dysgerminoma, radiotherapy is not effective. So, Sexcott stimulus, this is uncommon tumor, which is also usually low grade. And they have late recurrences, which should be treated with adjuvant therapy, right? Vinblastine, actinomycin, and cyclophosphamide, or vinblastine, bleomycin plus cisplatin. So, take home message of this ovarian cancer would be, so mostly as we discussed, ovarian carcinoma normally do not present at the earlier stages and always diagnosed at the later stages because the symptoms of the patients are not certain things which are related to gynec complaints, which are mainly mostly patient present with abdominal discomfort or abdominal distension, bloating sensation, nausea and vomiting sensation. Patients do not present with heavy menstrual bleeding or foul smelling vaginal discharge. So that's why patients do not present at the earlier stages. So according to the ovarian carcinoma, most common is the earliest epithelial carcinoma of the ovary is the most common ovarian cancer in older age group, and germ cell tumor being the most common tumor in the younger age group. And there's no specific method for diagnosis, screening method, because all has its own demerits, because CA-125 levels or being this one of the screening method is not has a poor sensitivity, and also CA-125 levels will be elevated in pregnancy, endometriosis, so that is not a specific screening method for the diagnosis. And also Roma Roca is also not specific a screening method. And coming to the management wise, mostly all these epithelial carcinomas managed with surgical staging. For surgical staging, for recollecting the surgical staging, first under general anesthesia, first supraumbilical incision, the midline supraumbilical incision is given. And after that, if the ascitic fluid is there, we have to send it for the sampling. And if it is not, the ovarian ascitic fluid is not present, ascitic, we have to instill 50 ml of normal saline and we have to send it for the cytology. And after that, if the after that, we have to see the systematic exploration of the abdomen, that is from the right side, that is cecum, after that ascending colon, and after that the right lobe of the liver, left lobe of the liver, and after the transverse colon and the spleen, and after that the descending colon and rectosigmoid colon. And after that, proceed with the and also we have to biopsy the suspicious areas. And after that, if there is no suspicious areas, we have to take biopsies from the undersurface of the diaphragm and also from the paracolic duct. And after that, we have to proceed with total abdominal hysterectomy with bilateral salpingo-oophorectomy, along with infracolicomentectomy and para-aortic lymphadenectomy. should be done. So this is the surgical staging. Normally, the low risk epithelial carcinoma, as we discussed, stage 1A, B, stage 1 and 2 are the low risk. And stage 1A, 1B only needs surgical staging and there is no need of the adjuvant chemotherapy. And in case of stage 1C and stage 2, we have to do surgical staging along with the adjuvant chemotherapy with carboplatin and paclitaxel for 6 cycles. And iris epithelial carcinoma, that is stage 3 and 4 carcinoma, the aggressive tumors, most commonly patients always present at this stage. So in this, the patient should be given first neoadjuvant chemotherapy, and after that followed by cytoreductive surgery. So in the cytoreductive surgery, the residual diseases should be less than 1 centimeter, and followed with chemotherapy for 6 cycles will be given. So after that, there is a question session. So what are the questions? Which of the following reduces the risk of ovarian cancer? So oral contraceptive pill, contraceptive implants, intrauterine devices, fallopian artery. As we know, oral contraceptive pills intake will reduce the risk of ovarian cancer. For 5-year intake of the OCP will reduce the risk by 50%. And 5-year intake of OC pills along with the tubectomy reduces the risk by 70%. So answer is A, OC pill intake. And risk factors for the ovarian cancer include which of the following? Yes, young age, nulliparity, multiple pregnancy, and prolonged use of OC pills. So risk factors will be as we discussed. Young age is not mostly it will occur in the older age group, and nulliparity, because nulliparity in this case nulliparity patient will not have a children. So after because of the repeated ovulation, because of the repeated DNA repair of the ovarian epithelium, so it predisposes to the epithelial ovarian carcinoma. So this the risk factor is nulliparity, and we'll see other options. Multiple pregnancies, that's a protective factor, and prolonged use of OC pills is also a protective factor. So answer is B, that is nulliparity. So which of the following is significant the pathogenesis of malignant epithelial ovarian tumors? So in this, number of ovulation a women experiences over a lifetime. So third question will be which of the following. So third question will be which of the following is significant the pathogenesis of malignant epithelial ovarian tumors? So the options are number of ovulations a woman experiences over a lifetime, history of dowsing, history of exposure to baby powder, and sister with a premature menopause. Here we already know that repeated ovulations will cause a DNA damage and the DNA repair. After that, it progresses to ovarian carcinoma. So answer is A. So, and the fourth question is a family history with a sister developed colon cancer at 40 years, mother with ovarian cancer at 38, maternal aunt with endometrial cancer at 45. What is the most common likely cancer syndrome linked to the mutation? So this is HNPCC, which is Lynch syndrome. Lynch syndrome, as we have discussed, which has a higher risk of colonic cancer and also endometrial cancer. Endometrial cancer risk is high, that is 70%, with a 12% risk of ovarian carcinoma. So this is HNPCC, which is due to the DNA mismatch repair. So answer will be D, that is DNA mismatch repair genes. BRCA1, that is not related to this. BRCA2 also not to this. So DNA mismatch repair genes. So answer is D. And the fifth question is which of the following is true regarding the staging of ovarian cancer? So A, stage 3 describes a disease which has spread to the peritoneum beyond the pelvis, and stage 1 tumors are common. Any pleural effusion equals stage 4 disease. The stage 4 describes spread to the capsule of liver or spleen. So A, that is stage 3 describes the disease which has spread to the peritoneum beyond the pelvis is correct answer. Stage 1 tumors are not common because always carcinomas are diagnosed at the later stage. And also any pleural effusion equals stage 4 disease is also wrong because any pleural effusion that can be due to other respiratory pathology also. The option should be in the pleural effusion with the positive cytology. That is, the cytology with the positive malignant cells deposit should be equal to stage 4 disease. Now, stage 4 disease spread to the capsule of the liver or spleen. That is also wrong. Stage 3 describes the spread to the capsule of liver. If it is stage 3, that is parenchymal the liver and the spleen, if it is involved, that is the stage 4, that is distant metastasis. If it is involves the capsule, that is stage 3C. So answer is A, that is stage 3. Disease describes the spread to the peritoneum beyond the pelvis. So next question. In treatment of the ovarian cancer, normally germ cell tumor requires TAH with BSO. Chemotherapy is the most important modality in the treatment of epithelial cancer. Optimal debulking involves surgery with no residual disease of more than 2 centimeters. An optimal debulking surgery has been demonstrated to significantly improve the survival. So answer A is wrong because always GCT occurs in the younger age group with the no completion of the family. So normally GCT will require the treatment of unilateral salpingo-oophorectomy with the chemotherapy. The patient do not require 2AH with BSO. And chemotherapy is the most important modality. That is also wrong. Always the surgical staging is the most important modality in the treatment. An optimal debulking, as we discussed, with it involves a surgery with no residual disease of less than 1 centimeter. So the answer is D, that is optimal debulking surgery has been demonstrated to significantly improve the survival. The optimal debulking surgery is, yeah, we have to remove the tumor as possible, as deep as possible, so that the residual disease should be less than 1 centimeter. The next question, which of the following is the true regarding the first line chemotherapy for epithelial ovarian cancer? So epithelial ovarian cancer, the first line chemotherapy will be carboplatin and paclitaxel. So following chemotherapy, the 5-year survival rate is more than 40%. And the response rates to platinum or taxanes are approximately 50%. The median survival rate is 2 to 3 years. The most commonly used chemotherapy is a combination of docetaxel and carboxyliplatin. So the following chemotherapy, 5-year survival rate is 70 to 80%. And response rates will be also very high, that is 70%. The median survival rate is 2 to 3 years, that is the correct answer. And mostly commonly used is, which as we described, carboplatin and paclitaxel. So thank you.